and there's like little tabs that these holes fit on. So once you get, this is pretty much all you have to do for your setup. If you do it in an OR room, usually there is an anesthesiologist present, so they are in charge of monitoring your patient's vitals. That doesn't mean that you do not also want to monitor them as well. You are a second pair of eyes, essentially. So is your nurse, all those people. If it's done in the patient's room, like in an ICU room, usually you are the person responsible for not only doing all of this, assisting your doctor, but you're also responsible for monitoring the vitals and silencing the alarm on your ventilators. When you bronch a intubated patient, because you're sticking the scope down their tube, that is going to increase the airway resistance, and your vent will alarm peak pressures, high peak pressures. So you either can just silence your alarm continuously every 2 minutes while the procedure happens, or you can change the settings on your high peak pressure alarm limit, but that is dangerous because if you forget to set it back down and your patient starts having issues with that, it's not going to alarm. So I typically just silence my alarm the whole time. Usually also when we're doing bronchs on intubated patients, we crank the oxygen up to 100%. Because again, we're kind of putting something in their airway that's blocking the flow of ventilation, especially down a tube. You know, a tube's already small. So we're also blocking that tube even more by putting a scope down there. So we're gonna increase their oxygen to 100% for the procedure. I think that's it. So yes, then if your doctor wants a BAL, that's when you grab all of this supplies. You take your original Lukens trap that you set up in line with your suction, you take that one off, and you put a new one on. You open your basin up, you put another new bottle that's completely unopened, and pour, a hefty amount into this basin, and then get another clean, completely unopened 20 ml syringe, and you're going to use this to pull out your 20 mLs of solution at a time, and you instill that whole 20 mLs down the scope, and then the physician will suck it back out. And they know specifically what lobe we're instilling the solution down into. So when we suck it back out, we will label the Lukens trap from what lobe it came from. So that's why we get a new Lukens trap, because it is a specific area that we're pulling that solution from that we instilled it in. Versus the original trap that we set up might be from all over, depending on where the physician was looking previously. Another thing is we usually try, and with our devices, always have end tidal hooked up. So with our mask, if we're going to use a mask, they do make end tidal capable masks now, bronch masks. So again, this is what the mask looks like. So this is the port for the mouth. There's a port for if you're going to go up the nose. Here is a oxygen port, so you can hook up oxygen in line. And then this is for your end tidal. So you hook up an end tidal line on that. Same thing if you're just going to put your patient on a cannula. You want to try and do an end tidal nasal cannula. So those guys have the little, I don't know if you can see it on there, but the little like pillow thing that goes underneath. Doctors will even do a nasal cannula and still go through the nose. Instead of putting the cannula through the nose, they will actually just stick it in the patient's mouth. And the end tidal will still work that way as well. So that is another option. So again, there's all different ways to do this. So once you're actually ready to start your procedure, your doctor will take their scope. They'll hold it out like this. They have surgical sterile gloves on. That's when you're going to take your gauze, and depending on what type of patient you have. If it's with this gel, this stuff is a lot thicker, so you can actually just stick it directly onto the gauze and it won't soak through really. And then you can like just taco your scope around it and slide it down. Versus the ET tube lube, it's very watery. So that one I usually kind of just hold my gauze underneath the scope and just sort of dribble it on a little bit. Oh, and one last thing, in addition to using this pen to label all your stuff, I also usually have an extra paper towel on hand. That way I can chart or keep note of all of the amounts of not only lidocaine that I'm putting down my patient's airway, but how much milliliters of solution you put down for a BAL. So when you chart your bronchs post-procedure, they typically will ask how much lidocaine did you give to your patient. So we chart not only the nebulizer dosage, the 3 mLs of a nebulized lidocaine, we also chart how much mLs of lidocaine we gave down the airway. So I will typically create just a little napkin, and I'll do like 1%, 2%, 4%, and then the BAL. So it's just chicken scratch, and then like I just do tallies. So I know like I always give, you know, if I'm giving 2 mLs, I'm always gonna give, you know, 2 mLs of all of these, 1 to 2 mLs. So if I give 1 for all of them, I'm just gonna tally. So then at the end, I know, okay, I have 3 tallies, so I gave 3 mLs of 1% lidocaine. So with your BAL, these are always given, this particular one is always given in 20 ml doses. So I'm just gonna create little tallies. I have, say, like 4 tallies at the end of my procedure. So 4 times 20 is 80. So I gave 80 mLs total. They will also measure out how much they got out. So you will chart not only how many mLs you instilled, but how many mLs you sucked out of your patient. So it's a lot of information to try to remember off the top of your head, so I like to bring in a piece of paper or a napkin or a paper towel, whatever you want to call it, to write all that down. Otherwise, you're going to forget, most likely. Oh, one thing I forgot to mention in the midterm video is you also want a brush, so a sample brush or a forceps. So depending on if you guys are going to be getting samples. So that will also be your requirement for the checklist of things that you have to grab. And I think that is it.